Hi, my name is Salman, and alongside my co-founder Vanessa, we are the Rex, and we are dedicated to shaping value-based care. The problem that we are attempting to tackle is patient non-adherence to prescription medication. 50% of patients with a pre-existing or long-term illness don't take their medications. Only 24% of non-adherent patients cite forgetfulness as a reason for not taking their medication, and 61% actively choose to not adhere to their medication. The problem also has significant implications, as it leads to 125,000 deaths annually, an increase of employer healthcare expenses by 20 to 25%, and costs the healthcare system $100 billion in direct costs. Furthermore, in Canada alone, non-adherence cost Canadian pharmacies $12.5 billion, translating to $1.3 million lost annually. As the scope of practice of pharmacists expands, enabling them to adapt and prescribe certain classes of medications, pharmacies are engaging in medication management to solve the problem. However, they are still engaging in transactional and reactive relationships with patients following non-compliance. Current technologies are attempting to motivate patients directly or indirectly through their care providers. There are reminder apps, pill trackers, and sensors that motivate patients directly. Providers can also simplify prescriptions, mail information, and enroll patients in compliance programs. And then there are some solutions that are a mix of both indirect and direct methods, such as bottle sensors and video conferencing apps that seek to motivate patients to take their drugs on the basis that physicians will be able to see their data. However, Frost and Sullivan have emphasized in their research that programs that involve personal contact or counseling with a healthcare provider are generally more effective than programs that rely purely on non-personal intervention, such as efficient packaging or automatic reminders. In fact, a meta-analysis that followed chronic care patients using technological solutions only showed an increase in compliance by 4 to 11%. Additionally, there exists a divide between physicians and patients in the use of technology. Physicians want to use technology to be more efficient in their practice, while patients want to use tech as a medium for information, but do not want it to replace their interactions with their healthcare providers. But even with physical interactions, we found that physicians only spent 49 seconds discussing new prescriptions with patients. At this point, it was clear to us that pharmacists were more engaged in the issue of patient non-adherence than physicians were. Secondary research showed us why 61% of patients chose to not take their drugs, and from that we deduced some things that they valued about medications. So, 20% said that they didn't want the side effects, meaning they valued safety. 17% said that cost was too high, meaning they valued cost effectiveness. 14% said they didn't need the drug, which we interpreted in that they wanted autonomy and independence in their choices. Another 10% had logistical issues with filling their prescriptions, which meant convenience was an issue, and another 1% said that they didn't know how to use the medication, which meant they valued education. But we needed to understand our customer segments on a different level, which was beyond their health conditions. So further research showed us there was a specific class of patients who were more non-adherent to their medications, and these patients are known as in control and involved, both of whom surprisingly tended to be more active in their health. Involved patients view themselves as partners with their healthcare providers. They conduct some research on their own and collaborate with their providers to come up with the best treatment plan for them. In control patients spend most of their time doing research and then tell their providers what treatment they want. Although only 37% of chronic care patients are found in these two subtypes, 40% of them have severe health conditions which are likely to stress the healthcare system more. Having developed better insights into our customer segments, we were able to identify the most important things they valued: information, involvement, collaboration, and relationships. What we realized about what they valued about medication adherence really had nothing to do with physical medications. The issue was about the value of their care. Knowing our involved and in-control patients, we realized technological solutions would not work because they valued relationships with their providers. Luckily, this can be enhanced by the expanding role of the pharmacists who are already engaged in medication management. But in order for this to happen, medication management needs to evolve into something like what we're proposing with the Rex. The Rex is a pharmacy clinic for chronic care patients seeking to play an active role in their health. Our pharmacy gives you access to resources and care you require to make informed decisions about your health. Unlike other pharmacies and clinics where pharmacists only push drugs, Our pharmacist will guide you and your interactions with our on-site healthcare team members. We are aiming to leverage appointment-based care, which has been proven to increase adherence to up to 80%, and a pharmacy triage system, which will convert transactional dispensing relations into high-value relationships. As discussed, our pharmacy will serve involved and in-control patients most active in their health and who value relationships. We will deliver this through our pharmacy and the use of a platform for booking appointments and sharing information between providers. We will also provide patients with their data which they can access through the platform. We will be forming intimate and close relationships with patients in the clinic, which includes booking follow-ups through the platform. Our revenue will come from medications, leasing clinic space to on-site healthcare providers, and from patient consultations. We will require physical space, capital, and a large amount of staff, especially providers, to run our clinic. Our key activities include problem solving, data collection, and outreach to maintain relationships with patients and get access to them. To help us with outreach, we will be developing key partnerships with chronic care associations who will educate our pharmacists and give us access to patients. We are also partnering with the University of Waterloo to conduct research. Our main costs will be associated with the building and equipment. So in order for this model to work, there are a few crucial hypotheses we need to test moving forward. First, patients value their pharmacists as much as their physicians. The value proposition of this model is dependent on this hypothesis being validated. Secondly, collaboration amongst providers benefits their ability to provide care. We are most interested in investigating the relationship between care providers in this kind of environment. If providers feel they are second fiddle to the pharmacist, it will pose a problem to this model. Third, patients will pay for consultations provided it is beneficial for their health. This will be a major source of revenue for us, so we need to make sure patients are willing to pay for these services. We do have evidence that involved and in-control patients are more likely to pay for healthcare services, but we need to assess their maximum willingness to pay. This will also help us understand the value of education, information, and care to patients. Lastly, pharmacists like the prospect of expanding their consultation duties. This will tell us if this type of triage model will work and if pharmacists feel as though they're equipped for this role. To address the hypothesis presented, we have developed a research plan which includes distributing a survey to determine their maximum willingness to pay. We have also partnered with the University of Waterloo to carry out interviews with patients and providers, from which we will conduct a thematic analysis to validate our hypothesis and pivot where necessary. In conclusion, we are building a pharmacy clinic that follows a triage and appointment-based model for in-control and involved patients who value information about their health, as well as collaborative relationships with their providers. We will be validating this model by working in partnership with the University of Waterloo and interviewing patients to understand their pain points, how they see value in their providers, where it can be improved, as well as seeing their maximum willingness to pay.